and this topic is on a very interesting topic, cataract coexisting with amblyopia. So amblyopia is a unilateral or a rarely bilateral decrease in visual acuity, which is caused by form vision deprivation and or abnormal binocular interaction, for which there is no identifiable pathology of the eye or visual. So this is the definition of mild, moderate, severe. I am not going to detail. We know what amblyopia is. So basically, the problem is twofold. One is is in infantile cataract, when we face cataracts in a child or in an infant, and then there is chance of amblyopia. And then in adults, when we might not be aware, but the patient has cataract, and we do the surgery, the vision doesn't improve. Probably the patient was amblyopic. So these are two scenarios, and obviously the infantile cataract needs more attention. So. So to prevent amblyopia in pediatric cataract, it's important that we identify the cataract, decide whether surgery has to be done. If it's like more than 3 mm, we are not able to see the fundus, no eye contact is there, there's nystagmus. All these patients will need to be operated, or there's squinting of the eye. So one decision will be whether we need to do the cataract surgery in a patient, or simply many of these patients are associated with cataract which is not exactly affecting the visual axis, the glow can be seen. And if we correct the refraction, many of these patients will be having astigmatic errors. If we correct the refraction in these patients, we don't have to go in for the cataract surgery in these infants. So a visually significant cataract is a 3 mm or a larger central opacity in the lens. And of course, infantile cataracts are most amblyogenic, so it's very important that we give our attention to these cataracts. And of course, we have to evaluate the cataract in children. There has to be a detailed examination, physical examination, ocular examination, laterality, whether it's bilateral or affecting only one eye, the morphology, the lens position, etc. The patient has to be examined under anesthesia, under GA, so that we are able to get the keratometry, the vertical diameters, and we're able to do a proper IOL power calculation. If we are planning to put an IOL, we need to go under GA to do a IOL power calculation. So the treatment modality would be to eliminate any obstacle to vision, such as cataract, correct any significant error, and force use of the poorer eye by limiting use of better eye by occlusion, penalization, active stimulation, pleoptics, etc. So we have to remove the cataract when the decision has been taken to do so. And then in a unilateral cataract, then we have to force the use of the poorer eye by these methods. So the management would be consider early surgery in young children with dense cataract. Of course, before that, we have to do the refraction to see whether vision improves with glasses. And then after the surgery, treat amblyopia. Or if we are not doing the surgery, then in cases of partial less dense cataract, then do patching or penalization. So how is pediatric cataract surgery different from adults? There's an elastic anterior and posterior capsule. If the visual outcome is it's not satisfactory, there can be amblyopia. Post-op inflammation is much more. 100% chances of PCO. Multiple surgeries might be needed, and of course, long-term issue and management. Because the refraction of the child will be changing, there can be glaucoma later on also in these patients. So these things have to be taken into consideration. So the goal of the pediatric cataract surgery is a clear visual access and visual rehabilitation, so that the patient doesn't develop amblyopia. Counseling is important, that long-term follow-up will be required. And if we are doing amblyopia therapy, again, follow-up and compliance is very important. So just to sum up, indications for early surgery in a child would be total cataract, unilateral cataract, asymmetric cataract, and associated features like nystagmus or strabismus. So this is basically how we are going to be doing a pediatric cataract surgery under GA mostly. And the next thing is the timing of the surgery, which is very important if you want to prevent amblyopia. So the decision to do the cataract surgery or to do the refraction, and then the timing of the surgery. And then how we are going to perform this surgery is all very important. So in case the patient is having unilateral dense cataract which is more embryogenic, we have to do between 4 to 6 weeks. Not before that, because we don't want to end up with a glaucoma in a small eye. Bilateral congenital cataract, 6 to 8 weeks. These are less embryogenic. Okay, there is increased risk of glaucoma if surgery is performed in first 4 weeks of life. And early surgery is required to prevent stimulus deprivation and amblyopia. So the timing for surgery for infantile cataract has to involve balancing the risk of early surgery, that is the risk of GA, intraoperative risk, versus those of waiting, that which can end up in amblyopia. The surgical approach to these patients would be lensectomy, antrovitrectomy, management of the posterior capsule. Another thing is whether to put a IOL or no IOL. There are varied, there's no particular agreement on whether to put a IOL or no IOL, but usually what we do is we wait for the IOL to be put till the child is 2 years when maximum growth has taken place of the eye, and then we put the IOL. I'm sure many people differ on this, especially in cases of unilateral cataract. Unilateral cataract, you might want to put an IOL earlier because it's very difficult. You can't have a phakic glass in one and the child is not going to wear it. So that is a point of decision making. Myopic shift. Of course, this is how a child's eye is different from an adult. It's not a miniature adult eye. And so we also have to take into account while putting an IOL that there's going to be a myopic shift with the increase in axial length in the child. So this is how we are going to target the post-op refraction. This chart according to age and what the target refraction will be, and accordingly we are going to place the IOL. Posterior capsular management is very important because 100% they'll be opacifying, so we have to do a primary posterior capsular access and an antrovitrectomy to keep a clear visual access. This cannot be overemphasized. How in a child it's very important to have a clear visual access. Okay, these are the post-operative complications, glaucoma, etc. Inflammation, lot of inflammation can be seen in these children. And then of course after the cataract surgery, first was the decision to do the cataract surgery, then the timing of the cataract surgery, then the method of the cataract surgery, and then of course after the cataract surgery has been done, the management of amblyopia, which would be first prevention and early detection of the cataract so that the amblyopia doesn't become dense, and then after the surgery is done to do treatment of the amblyopia. So the amblyopia therapy can be by patching, penalization, optic correction and pleoptics. And of course the follow-up is very important because every follow-up we have to see the visual acuity, the fixation, and then we might have to change the refraction with the length of the eyeball changing. So prognosis would depend on whether the cataract was unilateral or bilateral, the density of the cataract, the degree of visual impairment and the compliance of the patient. So managing amblyopia in a child with cataract requires a lot of effort and a lot of thought into different process of it. Amblyopia in adults is comparatively easier to manage. Only thing I think is the identification before surgery that this patient might be amblyopic, and accordingly we counsel the patient that he might not gain the desired refraction, the desired vision after the surgery. So how do we come to this conclusion that this patient, adult patient with cataract, is having amblyopia? We do biometry, and if there is difference in axial length between two eyes, consider possibility of amblyopia. Anisometric amblyopia is common with difference of more than plus 2D hyperopia and 4D myopia between two eyes. So apart from noticing, okay, that maybe this patient doesn't have this much of cataract but he's having this much of vision, you find a discrepancy, look at the other eye, see if there is any difference in the axial length, think that maybe there's amblyopia, counsel, and then proceed with the surgery like we do normally. So pre-op counseling is must. One thing would be to operate the non-amblyopic eye first so that the patient is happy with the vision and then go in for the amblyopic eye. To conclude, the important consideration for surgery here would of course be slit lamp examination, increase in axial length in growing eyes, we are talking about the pediatric eye, IOL implantation, whether to put an IOL or whether to leave it aphakic, then of course the IOL power calculation, how much we are going to target, be prepared for marked inflammation, 100% chances of after cataract, so in your surgery, do the primary postural capstraxis, the antrovitrectomy to keep the vision axis clean, and of course the management of amblyopia post-surgery. And I've noticed that sometimes when you tell the optometrist to take the vision in the child after you have done the cataract surgery, they don't take it properly. And I think this vision should be taken by the surgeon himself. Because I've ended up with a patient amblyopia because all the time the optometrist was saying the vision is 6'9", the vision is 6'9". To conclude, surgery alone for infantile cataract will not be successful without appropriate and timely optical rehabilitation and close monitoring for strabismus, glaucoma, and amblyopia. And in adults undergoing cataract surgery, biometry of both eyes to detect possibility of anisometric amblyopia and preoperative counseling is advisable. Thank you.
Thanks, Dr. for readily agreeable for presentation of Dr. Indu Pandey. Thanks. This ends our IC.
Do you invite questions? Do you invite questions? You mean to say that in adult, like you have to take the biometry of both the eyes, just for the prognosticating it, no? Prognosticating that, so that you should not have any surprises. The patient should not have any surprises. And the child, what were you saying? Again, repeat that thing. What precautions should you take before operating any child? Possibility.
That is important. That will create
Under GA.
Yes, in the smaller children, yes, it is very difficult to get the readings without GA. So you have hand, but we don't have, so handed kilometers, of course, there are there.
Sedate करके भी थोड़ा फिर आगे
Sedate करके.
अच्छा, मैं normal optical biometer में. तो after sedation, there is not many GA after Finargan पिलाके कर लीजिए, ठीक है.
लेकिन हम इसको बहुत ट्राई करते हैं because I hate to put the child through GA two times.
वही तो under GA that is main concern.
The GA is the main concern. ये बहुत मुश्किल होता है वैसे करना.
That is good. That is a good option. Axial length under GA, अच्छा. But then biometry under GA, how is it possible? You just please explain, na.
Refraction भी कर लो directly. Under GA तुरंत refraction भी कर लो.
नहीं, under GA how can you do biometry?
Handheld करके कर.
Handheld वाला.
Handheld से और axial length निकालना.
But what Rajesh said, na, is a more easy option. No sedation to GA only one point of time, and then you can do that. Put the patient on that biometer and just forcibly open the eyes with a speculum. You can